So I'm absolutely delighted to welcome for our next session my co-founder at VisLabs and a person who is, I'm sure, very well known to you all, Professor Mary Dixon-Wicks.
Thanks very much, Ruth, and delighted to be here. I'm going to talk about the role of discovery in improving maternity care, and I think we can all agree that maternity is currently a problem. Yet another thing that was specifically called out in Lord Darcy's report this morning, but an area that seems to lurch from crisis to crisis, from scandal to scandal, terrible stories of very, very bad patient experience and outcomes, and very, very bad staff experience as well. And we're now in a situation where it's a major area of concern at policy level, and where a majority of maternity units are judged to be inadequate or worse. What's also a problem is that although there have been multiple efforts to improve maternity care over the last 13 years, this analysis by James McGowan showed over 50 large-scale programs. Very few of them have been evaluated, so we don't know whether they have had any impact. And of those that have been evaluated, they demonstrate significant problems, including, despite the scale of the problem of inequalities in maternity care, not one of them has a focus on inequality. They also have many other problems, and the evaluations themselves are very weak. So we have a problem sector, and we have lots of improvement, energy and effort thrown at it, and so far not an awful lot to show for it. What we have is a challenge that we have way too many poorly supported, poorly designed, large-scale improvement initiatives that often feel done to people, that aren't designed on best practice principles, and that fail to engage and therefore don't deliver results. But we also, on the other hand, have way too much poorly supported, bottom-up improvement effort, where we have people working on small projects, often very fragmented, that lead to reinvention, to waste, and to suboptimal solutions. And I'm going to show you one of those a little bit later. But what accompanying that problem is the challenge that even when something does work, there's a failure to scale and spread it. And when something doesn't work, there's every chance that somebody else will try to do the same thing, not realizing that it doesn't work. We have aligned with this issue of way too much poor quality improvement, far too many improvement recommendations. So by one count, there were 1,250 different recommendations coming at the maternity system in 1 year. I recently spoke to somebody who was lead for quality in their maternity unit who had 903 actions. So that very quickly exceeds the ability of anybody to do anything. What we also know is that many of those recommendations are actually poor quality themselves, they're not grounded in evidence, and they aren't going to make the difference that we would hope for. So how do we do better in finding solutions that work? Well, the evidence is actually pretty clear on this, and I can refer you to the Cambridge Elements series, which, as some of you will know, is edited by this institute and attempts to offer authoritative overviews of the evidence on improvement topics. It's completely free to access, and it's published by Cambridge University Press. And what we can tell from the evidence is that if you want to get good solutions, you need to co-design using really good co-design methods. You need to do it at scale, and you need to do it inclusively. So that's where discovery comes in, because they're the capabilities that discovery delivers. And I'm going to give you 3 examples of how discovery has helped us to produce improvements that are valuable for improving maternity care. The first one is co-designing a process improvement. Healthcare is full of thousands and thousands of processes, but they're often suboptimally designed, or they may need to be tweaked in a particular situation. And one of these was when the pandemic started, and there was a need to essentially change processes so they could cope with a situation where the patient was COVID positive. And this is particularly challenging when there's an obstetric emergency underway, and you've got an infection control problem, and people have to be able to respond, but you need to do so in a way that's safe for the patients and safe for the staff involved. How we did this was use the example of a postpartum hemorrhage. This is a scenario that every maternity team knows how to handle. There are very specific things you have to do in a very specific order, and if you do them well, then you keep the patient safe and well. We illustrated how you might handle this in a situation where a patient was COVID positive by filming a short video of a team doing it. And we knew that this was not the perfect way of doing it, and in fact that was the point. We put the video on Discovery, and we invited experts to come and tell us what they thought of the practice that they saw illustrated. And they essentially got to watch the video on Discovery. There were over 100 participants, infection control people, people with human factors expertise, so these are people who understand how to engineer systems, and maternity staff. They watched the video and then they gave their recommendations freeform into Discovery on how they would improve what they saw. We actually got nearly 1,000 recommendations from that, but when you group them down, we could identify that there was about 22 of those that seemed to be the top ones. We then ran a Delphi study. So we got people to come back in again, and we said, these are the 22 things you recommended. We can't recommend all 22, so please tell us what your priorities would be. Discovery presented those beautifully, and they were able essentially to show using a visual dial how strongly they felt that that particular recommendation should be implemented. That enabled us to reduce down the number of recommendations, and we then presented them back out again. We showed people how they had scored previously and how other people had scored, and we said, could you please have another go at scoring? So that enabled us to get to 16 recommendations in total. We reshot the video to illustrate the new practice. We put it on YouTube. It had over 140,000 views. It was extremely popular. It's now been used to illustrate practice in areas way beyond maternity, including in surgery, because it was such a good illustration of how you do things like closed-loop communication, how you design your process so that you've got everything that you need in the order that you need it. It was endorsed by all of the major professional societies and by the Royal Colleges and by NHS Resolution, and most importantly of all, it was endorsed by Martin Bromley, who most of you will know is a patient safety advocate, and he described this as a gold standard for frontline human factors. So this was a great success, and that was only possible because Discovery enabled us to bring together people so we could do that co-design effort. So the achievement here was to show that if you use Discovery to do this kind of thing, you can build improved processes, you can build systems, you can do that collaboratively, and you can engage diverse and distributed expertise. These were people all over the country, and that was done in 6 weeks. So you can do it at speed and you can do it at scale. And we were then able to publish that as a methodology, which again has been extremely popular. So that's how you design a process improvement using Discovery. The next thing we tried to do was co-design what good looks like for a service. And antenatal care is consistently shown to be absolutely fundamental to good outcomes of pregnancy. It's very important in reducing inequalities because women from minoritized and disadvantaged backgrounds are particularly likely to benefit from high quality antenatal care. What happened during the pandemic was a big shift towards providing antenatal care, which has traditionally always been provided in person, midwife to women throughout the pregnancy. That shifted over to remote provision. And that led to a lot of questions rising about quality, but also equity and inclusion. Who's going to get disadvantaged by this? Who's going to get left out? Who might be additionally advantaged? So it raised many, many questions, and we wanted to answer those in a timely way to inform practice and policy. And this is again where Discovery came into its own. So we were able to use Discovery to build a quality framework for remote antenatal care. Essentially, we were able to use it to consult with women, with healthcare professionals, and with system-level stakeholders, people like NHS England and commissioners and so on what good would look like for remote antenatal care. So we were able to run a survey very quickly and very easily using Discovery, and we were also able to run online interviews. That's one of the capabilities that Discovery offers. As Joe described earlier, you can book your interview all in one integrated thing like when you book your hairdresser, and you can, you've got a link that goes to the patient and to you, or the participant and you. You can open it up in Discovery on the day, so it's got a screen for you and a screen for the person, and you can do the consents and so on. So it's an extremely smooth process that enabled us to do these interviews in pandemic conditions very quickly and very easily, and we got excellent geographic spread and diversity. So that enabled us to be very, very clear about the 7 features of good antenatal care, and we were able to summarise that in ways that were very accessible and useful to those who are trying to design services. So we were delighted that that ended up being one of the top research articles of the year in BMJ Quality and Safety. Was featured in their goodie bag at the International Forum as an example of one of their great papers. But even more importantly, it was featured in the NHS England Maternity Transformation Programme Bulletin. It's been reported as an example of good practice by the World Bank and by the Australian Commission on Quality and Safety in Healthcare. So this was a project that we were able to do because Discovery enabled us to do it, and that then went through to actually have the impacts that we were looking for. And my final example then is co-designing major changes in clinical practice. So again, we have a situation in maternity where there are an awful lot of processes that need to be done well, and an awful lot of areas of clinical practice that need to be very well supported by clinical evidence, but there may be challenges in converting that evidence into what people need to do. Now, what we know from the reports to NHS Resolution, so this is the litigation authority for the NHS that handles claims for clinical negligence, is that one of the most significant contributors to avoidable brain injury in childbirth is when there's a failure to detect the baby that is deteriorating during labour and to intervene on time. Now that is, when a brain injury occurs in that way, it obviously has an absolutely devastating effect on the families, which can be potentially lifelong, and because it may result in a child with very, very significant impairments, that child is going to require support for life, and therefore the claims to support those children can be huge, of the order of about 35 million. So that has a very significant impact on NHS finances. Maternity is currently the area of negligence claims that accounts for about 50% of the value of claims, and it's also a very, very bad experience for staff when they are engaged in an incident involving a brain injury. So this is an area that really does need absolute focus. What we know from biomedical science is that there is very clear evidence that you should be monitoring a number of different clinical risk factors at the start of labour and then throughout the labour. So, for example, this study of what predicts adverse outcome in neonates shows that meconium is one of the, so this is when the baby gets into distress and basically does a poo, which will then appear, that is a very, very significant predictor of a bad outcome. You need to start intervening very early if you see that sign. It also appears about 2 weeks earlier in black women, so a significant risk factor that you need to be monitoring in order to reduce inequalities. So one question is, how do we get that kind of evidence systematized and built into the processes for monitoring the baby and then responding during labour? A second and neglected area of focus is work system design, and this work we did on why is intrapartum electronic fetal monitoring so hard showed that there are all kinds of things that contribute to suboptimal practice in terms of detecting and responding to the baby who's deteriorating, and some of those are to do with equipment design, some of them are to do with poorly designed processes, teamwork, and so on. So we were very clear about what it was that needed to happen to improve these systems for detecting and responding to the baby who might be deteriorating during labour. We needed to turn the scientific discoveries and the human factors analyses into practical actions. We knew that there were too many technical solutions to what was actually a socio-technical problem, and we also had poor standardization, so different units using different ways of trying to do to address this problem. And what happens when you don't have co-design at scale and don't do things well is what happened with obstetric early warning scores. So what you're trying to do with an early an obstetric early warning score, and it's find the mother who's deteriorating and then intervene on time. Because there has until very recently been no national way of doing this, we have 147 different ways of doing this. Huge variation in what's considered to be normal depending on which unit you happen to be in, huge variation in what the thresholds are for taking action and the nature of the required response. So in that review, over half of the units considered the temperature to be severely abnormal when over 38 centigrade, but in 6 units a temperature of over 40 was considered to be only mildly or moderately abnormal. We also found massive variation in what they consider to be significant in terms of respiratory rate. So what's happening is not only that you have poor standardization of practice and chaos, but there's also an enormous amount of waste going into this. So every unit coming up with their own way of doing this means that we generate an awful lot of wheels, and we also generate an awful lot of waste. So this is just a silly way of doing things, let's be honest. We could just do a lot better if we did proper large-scale design right from the beginning using co-design methods, and we engage everybody at scale. So that's what we did in order to address this issue of how do you detect and respond to the baby who's deteriorating during labour. And we've published this to show how we did it. So essentially, we were co-designing really practical tools to improve care, and this was all facilitated both by Discovery and by complementary offline activities. And I think it's absolutely, I really like this strapline of Discovery, because what it does is connect people asking the questions. In this case, it was the Department of Health and Social Care said, please can you help sort out this problem? How do we find the baby who's deteriorating labour and respond on time? How do we connect that question to the right people to answer them? And we were very clear that the right people to answer this question was the staff and patients of the NHS. So the first thing we did was went out and asked staff to tell us, is this a problem for you, and would you like a better way of doing this? And Discovery again enabled us to engage at scale. We got a very high response rate to this, and what we were able to show very quickly was, in fact, there was huge support for an approach that would personalise assessment of the fetal deterioration, and also, and this is very important, huge support for a national standardised approach. So that gave us confidence that there would be acceptance of this and that people were prepared to be engaged in it. What also very importantly, what that did for us was show that although people were very keen to monitor risk factors, and they agreed with the 7 that we were proposing based on the literature, they also were unclear about some of the definitions. So they wanted more clarity on the definitions. So it was clear from that analysis that one of the things we needed to fix was how do we define these in ways that are meaningful to people who are looking after patients on the ward. So again, what we were able to do was use Discovery to get staff to essentially consensus build what the definitions were going to be, and we were able to do that very successfully. So now we've got a list of indicators and we can define them. The next thing we needed to do then was come up with a tool that people could use to assess the baby during labour, and we designed that using human factors principles, and we were able to interview people using Discovery, where we got them to work through a clinical scenario using 2 different versions of the tool. Again, that was very successful. The offline bit involved shadow testing. So what we did was got clinical teams and we ran them through a simulated scenario, so we could essentially improve the tool further and figure out what needed to be improved in terms of work system design. At the same time as we were engaging with staff, we were also engaging extremely deeply with women and birth partners, again facilitated by Discovery. One of the first things we did, for example, was use a vignette. Discovery is great if you want a little video or a little vignette, show a little animation to show something, and then you get people to give feedback on it. So that enabled us to figure out what does good look like if you are a woman in labour or the partner, and helped us to develop 5 principles for good communication and making decisions that are Montgomery compliant with the family. So that was absolutely key, and again, very, very important that we were able to use Discovery to do it. And the results of that fed back into the tool and into the simulations, so we were able to improve them. Again, that paper was identified as one of the top research articles of the year of 2023. But again, more importantly, as well as its kind of academic credentials, it is now the standard written into the NICE guidelines, and is about to be, there is a pilot planned before it goes to national implementation. The other area that we were working on as part of avoiding brain injury in childbirth was the problem of impacted fetal head at caesarean section, which is such a horrible problem I won't describe it because we will all squirm, but it is the contributory factor in nearly 10% of the most expensive maternity claims. It's now thought to complicate about 1 in 10 emergency caesarean births and about 1.5% of all births. So this is a very significant problem that is very, very traumatizing when it happens. We discovered very quickly that there was no consensus on how you even defined it. So again, what Discovery was able to facilitate was getting to a definition that everyone could agree on. This is what an impacted fetal head is. What we were also able to do on Discovery was identify that there was very, very high level of support for multi-professional training. We were able to show that although there are different ways you can disimpact the fetal head, which you need training in, that there was variation in how people viewed those, and unfortunately some evidence that professionals were using practices that were probably unsafe. So we were able to highlight that as an issue. Again, very, very deep engagement with women and birth partners, and again using deep engagement using Discovery, we were able to build on principles for communicating during this obstetric emergency. So the result of all of that was new clinical tools, training, communication, and teamwork principles, which, as I say, are going to be go into pilot soon. We were also able to look at the issue that you can design all these things as well as you like, but how do you get them to actually implement in practice? And so again, Discovery was crucial in being able to engage very deeply with system stakeholders and staff on what the challenges were likely to be in implementing this. Again, we've got a lot of publications, but essentially what this is showing is that this is a way you can do engagement at scale, you can build solutions, and you will also be able to test them. So to conclude, what you can do if you're trying to improve and innovate in maternity care, and goodness knows we need to do it, you can use Discovery to help you to do that. It facilitates co-design, it facilitates participation, and very importantly, it facilitates ownership with a clinical community that is feeling increasingly beleaguered. You can create at-scale solutions, and you can enable their testing. You can do this speedily with rigor, and you can minimize waste and frustration. And because you're using this participatory ethic to guide what you're doing, the solutions are much more likely to be accepted and effective. So I think what we can conclude is that Discovery helps to do better at doing better. Thanks very much.
Does anyone have any, very quickly, any questions for Mary, just because we're running short of time again? Well, oh yeah, Adam.
Sorry.
Hang on, let me give you the...
I'll repeat the question.
Yeah, you mentioned at the beginning maternity services rates in Africa has improved, and allusion to the CQC, which is probably right disruption. I wonder if you thought there's an application of this in terms of what the CQC does at the moment. And perhaps slightly more rigorous investigations to the quality of services beyond someone running a bigger rigorous shop.
So the question is, could this help the CQC do better and improve quality of inspections? I think there is a role for Discovery and these kind of co-design methods in doing many of the things that we need to do better in healthcare. I agree inspection is one of them, and I think you can do a lot to look at what does good look like using these kind of methods, so definitely.
that as a, I mean, so if you're proactive, sometimes that helps. But sometimes it unnecessarily complicates the, I don't know how to express it better.
Okay, so I think the question is there a risk that this could complicate things rather than delivering the simplicity that we might need? I think that's why co-design is so important, because we all have ideas and we all have kind of views on how things might be best, but if you use co-design really well, then you listen to everybody and you can build something that is most likely to satisfy people. I think what's happening here is that we're simplifying rather than complicating, and we're systematizing an awful lot of evidence into practical solutions. I can see Ruth is keen to move on, so I will, thank you.